Hi everybody, this is Dr. Ihya Abdurrahman Hattarawa, consultant of acute care medicine at Soba University Hospital, professor of medicine, University of Khartoum. We are still doing our course on medication safety, medication without harm. We will continue discussing causes of medication error. In this session, we are going to discuss commissioning errors. Learning outcome identifies the most common types and causes of medication errors that occur in acute care setting. Describe why medication error occur. Understand ways in which you can help to prevent medication error from occurring in your workplace. There are many factors that can affect medication dosing, including medication selection and dosing, including age, weight, comorbidities, kidney and liver function, current medical status, current clinical observation, and the indication for the drug, plus the route of administration. This is a case scenario. Susan is a 38-year-old female admitted with pyelonephritis, started on ceftriaxone 1 gram every 24 hours. On day 3, she was still febrile, tachypnic, hypotensive, transferred to high dependency unit, and the medication was changed to meropenem 1 gram every 8 hours. On the same day, the consultant noted that she has neck stiffness. So, and meropenem was escalated up to 2 gram every 8 hours. On the 6th day, she developed septic shock and acute kidney injury requiring renal replacement therapy. Patient clinical situation may be continually changing. Medical team must review medication on regular basis to ensure that prescribed dose continue to be appropriate. Before each administration, nursing staff should assess whether the drug and dose are appropriate, paying particular attention to the patient's current clinical status and observation. In the previous scenario, initially the dose was appropriate for simple pyelonephritis. When she became more sick, then the dose was changed to carbapenem 1 gram 8 hourly. But when they discover that she's having meningism, then the dose has to be escalated to 2 gram 8 hourly for meningitis. When she developed acute kidney injury, the dose need to be modified. And while she was on CRRT, then the dose also need another modification while in CRRT. Calculation, accurate patient weight is very important. General estimation sometimes could be wrong. Always double check your own calculation, and if possible, have someone else to verify your final dosage. Confirm that the milligram per kg per dose meet acceptable dose range. For example, gentamicin, the dose range from 3 to 7 milligram per kg. If a patient weigh 75 and you are giving him 4 milligram per kg, the calculated dose will be 300. If it is not contraindicated, you can approximate the dose to 320 since the vial has 80 milligrams, so you can give him 4 vials. But if this is exceeds the clinical indicated dose, then you need to stick to that dose. Calculate the corresponding volume to be given in ml for liquid medication. The dose of some medication may be different for different routes. This is because bioavailability varies according to the route of administration. Ali is currently receiving 2.5 milligram of intravenous morphine for pain relief, and then he become more stable and you are trying to switch him to oral medication. The bioavailability of oral morphine is 30% of the intravenous dose. So 2.5 will then equal 7.5 milligram. So we have to consider when we are switching from oral to IV or from IV to oral, we have to consider the bioavailability of the medication. Poor prescribing as a cause of dose error sometimes can be related to unclear handwriting. If you see this prescription, the metoprolol, is this number 95 or 45? You have to write very clearly so that the pharmacist and the nurse can check and give the appropriate dose. And also, it is the responsibility of the pharmacist and the nurse, when they are not sure, to call the doctor and verify the dose. Poor prescribing as a cause of dose error, the use of confusing abbreviation, Roman, numerical, or fraction. Here, this is insulin, and the doctor may be intended to give 8 unit, but it look like 80. So it's better you write unit, U-N-I-T, rather than 8 plus U. The use of trailing zero after decimal point can be a source of confusion. This dose is 2, but sometime in a confusing night you can miss the 0 and you can read it as 20 milligram. Avoid trailing 0. Also, when you are writing in a decimal point, try to use a leading 0. This is 0.5, but people can read it easily as 5 milligram. So try to use the leading 0. Use leading 0 in decimal and avoid trailing 0. Writing over mistake. Here, this number, is it 20 or 40? So you need to write clearly. When you cross a number, just write another number instead of writing over it. One of the source of confusion is prescribing dose by volume. Here, this is like a Roman 4, and it doesn't, whether it is 4 or IV, it's a source of confusion to all staff. Prescribing over multiple routes of administration. Here, medication is haloperidol, 5 milligram, IV IMPO. And for elderly people, 5 milligram could be a very high dose if given intravenously. Another source of commissioning error, when we give the medication to the wrong patient. Ahmed in bed 16, and he is recently transferred to another bed. He was supposed to do CT scan with oral contrast. Another patient was admitted to his bed, and fortunately that patient consumed 80 ml of oral contrast. This was realized after he consumed all the medication. A minimum of 3 patient identifier must be used to ensure that medication is given to the right patient. Generally, use the patient name, medical record, and date of birth. Also, you need to identify and document allergy. Adverse drug reaction must also be confirmed. Never assume that the patient on the right bed, or even if the name is written there, the name could be of the previous patient. Try not to refer to patient by procedure or intervention. A woman who had a complicated cesarean section, a girl who had surgery this afternoon, or a man with cellulitis. Refer to them by their name and use other identifier. Wrong time, preventing timing error. When writing new drugs, when writing new drug order, the prescriber must write the frequency and administration time accordingly. A patient was noted to have low blood pressure, and he was on metoprolol XL. This is extended release, and it's usually used as once a dose. Unfortunately, it was written at 6 and 2000. The patient ended up taking 2 doses, and then he developed hypotension. Factor to consider: entering the administration time allows the prescriber to be explicit about the intended treatment schedule. Where possible, the prescribed administration time should be in accordance with the standard schedule of the hospital. For example, in some hospital, when we write morning, they give it at 8 o'clock in the morning. Night, they give it between 6 to 8 o'clock at p.m. Twice a day in hospital doesn't mean every 12 hours. They give it at 8 and twice a day. They give it at 8 in the morning, and 8 p.m. 3 times a day, they give it at 8 in the morning, at 2 in the afternoon, and 8 p.m. Regular 6 hourly, then it's given at 6 hour interval, but 6 hourly, sorry, regular 8 hourly, it is given at 6 in the morning, 2 in the afternoon, and 10 p.m. So you can, it's better you go with the hospital scheduling so that you don't burden your nursing staff. Wrong drugs, some drugs they look alike and they are very confusing. As you see, this packaging are very confusing, and some drugs are, they sound alike, lorazepam, alprazolam, and you have to be very careful in LASA, look alike, sound alike medication. Commissioning error can occur due to wrong calculation, due to changing patient status, wrong dose, or poor handwriting, wrong patient, wrong time, especially for variable dose, wrong drug by look alike and sound alike, and thank you.